I'm going to be talking about beware stroke mimics. This chapter, it's page 123, I think, in your manuscript or in your book. All right. So, why are we talking about stroke mimics? What is this about? Whoa. Speak it out. In unison. TPA, thank you. Okay, so we should just get that out front, right? I mean, there's lots of reasons to care about stroke mimics. It's embarrassing to be wrong. You say someone's had a stroke and turns out they had a seizure. That's just, generally embarrassing. But that's no more embarrassing than making some other bad diagnosis or incorrect diagnosis, and then later getting a note from, your friendly neighborhood cardiologist or neurologist saying what a dummy you are and all that stuff. But for the purposes of our practice, there's a special case for stroke mimics because of its the potential use of TPA. Now, this lecture is not all about TPA at all. And in fact, I think there's an acute ischemic stroke chapter coming up. If you haven't, I don't think it's come up yet, but it's probably tomorrow. And they'll talk about TPA in more detail. But suffice it to say that TPA is of marginal benefit at best. Okay? Well, I'm not going to get too controversial. It's marginal benefit at best. Even in stroke cases, where it has no potential benefit, is in non-stroke cases. Okay, if you don't have a stroke, unless you happen to be having an MI. If that's your stroke mimic, that you're having an MI, it might be of value. But what's that? Or P, if you're having unilateral weakness as a consequence of your PE, then TPA might be of some value. And even there, it's pretty controversial. So it can't benefit you if you're having something that's not a stroke. So it's probably and it can certainly harm you no matter what. It's definitely a disease, even in healthy brains, that causes bleeding somewhere in the order of, a little less than 1% of the time. Brain bleeding, bad brain bleeding. So we got to know about stroke mimics. But that does bring in the next piece of this which is, what would you think of if I say, what's a stroke mimic? Just give me something on the differential. We'll cover them all eventually, but what would you give me one? Complex migraine, beautiful, okay? Complicated migraine is, in fact, we're going to get to that one very quickly. And those are the things that I think we typically think of as a stroke mimic. So I just want to get up front of the definition here and say, in this particular case, because this is really a functional definition, it's what is going to cause symptoms that I should not give TPA to, right? That's the definition of stroke mimic for the purpose of this talk. And that's going to include the usual sundry list of seizures and complex migraine and things of that nature, conversion disorders, etc. But it's also going to include a couple of things that we might not think of traditionally as a stroke mimic. For example, it's going to include hemorrhagic stroke. Okay? I mean, a stroke mimic, it's called hemorrhagic stroke. That seems like it's not a mimic, but it is a mimic for the purposes of this diagnosis because you can't give them TPA. So a stroke typically comes in an ischemic variety, a hemorrhagic variety. We're going to call the hemorrhagic variety a mimic. Similarly, we're going to call a TIA a stroke mimic. Okay, because you can't benefit from TPA if you got better without anything. And lastly, we're going to consider, or at least begin to consider, the concept that a lacunar stroke is a stroke mimic. Right? Because TPA doesn't fix lacunar strokes. That's a different pathophysiology. Lacunar strokes are these little micro-perforating branches that get in and infarct a tiny little piece of your thalamus or internal capsule. TPA doesn't affect even the pathophysiology of that. TPA dissolves big clots that form in your MCA, ACA, or PCA. That's what it does. So, for the purposes of this discussion, we will at varying points consider all of those things to be stroke mimics, and strokes are going to be a big anterior circulation clot. Okay, so just to get that out front. Now, with that introduction, let's go right into question number one. So, what is it? How frequent is it, etc. This is conditions that mimic stroke in the emergency department, implications for acute stroke trials. This is an older study from 95. It got a huge amount of publicity because it was almost coincidental with NINS. It's a landmark study out of the Long Island Jewish Medical Center in the Archives of Neurology. And basically what they did is they had a bunch of people who were admitted with stroke, diagnosis with stroke. The artificial piece of this paper is you had to make the diagnosis before you got the head CT. Okay, so you got the head, so you said, this is a stroke, admit it. They activated their stroke system, and then they went on and then followed those patients over time to see how many of them ultimately had a confirmed diagnosis of stroke. And what they found was we weren't that good without a head CT, at figuring out who had a stroke versus a mimic. And they introduced the term mimic, or at least popularized the term mimic in this particular paper. What they found was 81% of the time we were correct. But that's 19% or 1 in 5 where we were incorrect. And they went on to go ahead and list out the sundry reasons that we made mistakes. And they included stuff that you would expect. The patients were postictal. That was really common, among the more common ones. So a little Todd's paralysis or something like that. The next one was systemic infection. So you had an infected person, they were septic, they were encephalopathic from their sepsis, and that was frequently a misdiagnosis of stroke. That happened about as often as the postictal cases. A goodly number of them also had CNS tumors. Okay, now that's an artifact of them having had made this diagnosis prior to the CT scan. All right, but nonetheless, CNS tumors and mass lesions was a common mimic, almost as common as the other ones. And then the other ones were a list of toxic metabolic complaints, hypoglycemia, hyponatremia, each of which was rare, but when you add them all up into these metabolic derangements, they were modestly common, somewhere in the neighborhood of 16% of mimics were those. And then our friend, the complicated migraine, which is what was the first and the sort of the most classic mimic, I think, in some ways. This is the landscape, 1995. This is going to be our baseline, and we're going to talk about subsequent literature, et cetera, and where we're at in today's world, 17 years later. They did find that decreased level of consciousness was associated with much higher odds of a mimic. Okay, so if the person is mentally normal but physically unable to move their arm, that was a higher risk of a stroke, and if they had depressed level of consciousness, that wasn't. Other things that were found to be associated with stroke were AFib and history of vascular disease, etc. But when they ran the numbers and tried to find some constellation of symptoms and signs that would help us figure it out in real time, is this the real deal or not, they didn't even come close. They also had small numbers, and we'll get back to that. So I'd just like to highlight the complicated migraine. So I actually am going to jump way forward. I jump around a lot in the chapters that I haven't specifically written. The limping child didn't jump because I wrote that one. But this one, I'm going to jump up to number 11 just to talk about complicated migraine. I think you don't have to flip the pages if you don't want to. It's not that, the abstract itself isn't that interesting. But complicated migraine just highlights how difficult this situation is. So who's treated one of these recently? Right, okay. And was it a first-time diagnosis or not? Yeah, okay, so let's talk. So the one nice thing about this article, number 11, is that it sort of goes through what the typical features of our complicated migraine. Unfortunately, it's not that great for us because the average age at onset of a complicated migraine is 36. Now, it's a little bit younger than the average age of a person suffering an acute ischemic stroke, but I'd like a couple more decades separation between the two averages there. I'd like this to be 15 and the other one to be 70 instead of 55 and 36 with a whole heck of a lot of overlap in between. So it's tricky for sure. Almost always associated with a headache, which is great news because strokes are infrequently, or at least what we're calling a stroke. Hemorrhagic strokes frequently have a headache, but what we're calling a stroke is infrequently associated with a headache. But there's all sorts of other features that we would not necessarily think of with a migraine that are going to confuse the picture. And they include that patients often have sensory problems with these complicated migraines. We learn that it's a unilateral weakness, which is a little atypical for a big stroke, right? Usually if it's a big stroke, you get motor and sensory deficits. But these migrainoid patients also frequently have sensory stuff. They often have a little bit of confusion. They often have interictal weakness, things like that. It can wax and wane a little bit. Things that actually are kind of similar to stroke or TIA-like symptoms are very common in complicated migraine. So this is really tricky. And then, of course, the complicated migraine it gets better in how many hours? Or how many minutes? Did your patient get better right away? Oh, well, that's actually pretty good. The typical duration is 8 hours. So if it's an hour, maybe you can sit on them and just be like, oh, come on, start moving your left arm, left arm, left arm, left arm. You might get lucky. But the problem is that most of the time they're going to remain paralyzed with a CT normalness and acting like they're just hemiplegic with some sensory deficits, and you're going to be sitting there going, God, I know that this is 36 years old. It seems like a complicated migraine, but this is going to be a very scary clinical situation. Now, the good news is they tend to be recurrent. So you tend to, the patients tend to come in for their medication for the migraine and not for, because they think they're having a stroke. But that first time, they're going to wind up in the ED. I mean, if I became hemiplegic tomorrow, even with a headache, obviously you're coming to the emergency department. So good luck. And this just highlights what a difficult job it is that we have to do, especially under a time frame of, 3 to 4.5 hours to administer TPA. So now I'll go on to abstracts 4, 5, and 6. I'll start with 6 because it's just sort of the bigger of the studies. It's what does subsequent literature suggest about stroke mimics? So we talked about the stuff in 95. This is a little bit later. There became a big debate in the literature that was one of this. It was this thing came out and said that there's a lot of mimics. We can't diagnose it very accurately. And then there became the issue of finger pointing, right? Oh, no. I can diagnose it. It's you dummy ER people. Oh, no, it's the mid-levels who can't diagnose. No, it's the paramedics who can't. No, the neurologists can do it. We can't. Everybody. There's got to be several articles here that are all about finger pointing, where we say, no, it's just those ER docs. They just need to, be better. They need to be better doctors. So abstract 6 is one of those types of papers. It's the generalists against the neurologists, not the emergency physicians, because it was in France and they don't really have emergency physicians. It's misdiagnosis in 2550 consecutive patients admitted to an acute stroke unit. It's 1,200 people, so big giant study. They were admitted by a generalist into the stroke unit. The next day, the neurologist came with his giant reflex hammer and went in there and banged on people's heads and stuff like that, and then said, aha, no, you guys were wrong 20% of the time. All right. In fact, it wasn't quite 20, it was 14% in this particular case, and the misdiagnoses were the same potpourri as the last one. There were some tumors in there, but because they had seen the CT scan, that was less frequent. They had already seen the CT prior to making the diagnosis, but complicated migraine, seizure, peripheral vertigo starts to show up a lot when people have these, strange vertiginous symptoms that are, very challenging for us to sort of tease out in the emergency department. Those were the main categories, and toxic metabolic were the main categories that showed up as a stroke mimic in that study. So this is one of those studies where it says, see, it's just the generalists aren't that good at it, and maybe if the neurologists did it. Number 4 is a rare study that suggested that we're actually a little bit better than some of the other studies have said. This is 441 people hospitalized with stroke. It was either hemorrhagic or ischemic. In this case, they got the CTs, and they found that the ED doc, when they said you're having a stroke, was right 95% of the time. Still a 5% miss rate. What's interesting is that this study, the conflict of interest is that the author was on all the TPA studies. So they had there's reason to believe that they had an impetus to say that we were a little bit better than we really were, and the methods were sort of skewed towards us doing well. But I like that we're good doctors, and I generally respect that. So far we've got in the neighborhood of 5 to 19% stroke mimic. Number 7 is another one that says, oh, these non-neurologists can't handle it. It's kind of a funny little study out of Portugal. It's to show that Portuguese non-neurologists can't diagnose strokes particularly effectively. It's a very small number. I can't remember exactly. 52 people. 85% of them were found to have stroke, but then again, 15%, same number. We start to see this 15%. You're going to be wrong 15% of the time, over and over and over. And then we get to number 8, which is a really important paper, probably the most important in this sort of what's the prevalence of because number 8 is, first of all, it's titled Limitations of Clinical Diagnosis in Acute Stroke. It's in the Lancet, so you know it's going to be good. And it's getting closer to the real question, because up until now, all these other papers, I've sort of given a pass on the idea that the neurologist is the gold standard. So when the ED doc or the generalist said it was a stroke, and the neurologist then said it wasn't a stroke, you said, okay, the neurologist was correct. And the other thing that we did in all these other papers is we let the neurologists see them whenever the hell they wanted to see them, and we compared it to final diagnoses and stuff like that, right? And that served as the basis for saying emergency physicians and generalists can't do that. But what we didn't ask is, in real time, at time equals 3 or 6 hours when it's really important to make the diagnosis, are these neurologists actually any good at doing this? Are they really better? Should they be the gold standard compared to us? So in this particular study, what they did is they got everybody an MRI, okay, at 6 hours or within that narrow window where we would be thinking about potentially doing some interventions. And they said, okay, now how accurate are we? In this real-time moment, using the MRI as a gold standard, and they used their stroke neurologist to make the assessment. It's a relatively small study. It's hard to find that many people within that specified time window, et cetera. They had 70 people with stroke, each with symptoms less than 6 hours, so they might have been a candidate for some form of an acute intervention like TPA or some other, vascular retrieval device or something like that. And the results here are pretty scary. Okay, so they found that only 70% of them were correctly classified. So 70% of the 70, or 49 people, were correctly identified as having a big clot, or at least anterior ischemia. The remainder of them, 10% of them, had totally normal vessels. So they had the true mimic, the complicated migraine, the seizure disorder, something like that. The other 21% had TIAs, lacunes, etc. So something that you might not necessarily traditionally consider a mimic, but would be something that is not likely to benefit from TPA. So we're talking about 30% of the people didn't have that. When they went further, they looked and said, how many of these people have a fresh clot inside of one of those big arteries? So not just was there evidence of ischemia in that arterial territory, but do they have a clot in there? Because that's what this drug does. It dissolves that clot. If there's no clot there, there's nothing for it to do except cause your brain to bleed. Okay, so they looked at that and they found that half of the people with the ischemia, the anterior ischemia, the ones that we correctly classified as having anterior ischemia, there was no clot. There's nothing to TPA. Right? So this is now you see why TPA at best works on the margins. If, the large majority there's a section of people that were missing, there's another section of people that are having lacunes and other diseases that can't possibly benefit, and then there's the people who are having the big stroke, the perfect candidate, and they've already recanalized. Right? They don't have a clot anymore. There's nothing left for TPA to do. And then there's the ones that have the clot. You have a question, please? Yes.
People who give TPA say that it doesn't matter if you have a clot or not.
Yeah, well, of course they do. What choice do they have? I mean, no, I understand. I understand. They'll say, and we'll get to that at the end of this a little bit, but that has been the counter argument. So for years, though, what actually happened is they went the other direction and they said, oh, no. You need to have, the reason that, the results aren't that great is because we're not giving it to people that have clots. So we got to get more specific, be better at diagnosing stroke. But this literature shows us you can't do it. You can't do it. You try to get better, you try to get smarter, you give them a CT, you get good people to read it, et cetera, and you still have these 10 and 15% miss rates. So then there's a wholesale change in the literature where they say, well, it doesn't matter if it was a stroke or not. It doesn't matter if there was a clot or not. Just give TPA. It's good for you. It's a vitamin. It's vitamin TPA. So anyway, that's a very good point, and we'll get into that just a little bit more in the future. So anyway, at this point, we're saying that there's not, with people even with stroke, they're not reasonable candidates for TPA. Not my words, the author's words from abstract number 8. I believe they said that only 30% of people were rational candidates for thrombolysis, of the people that they thought were reasonable candidates going in. So take it for what it's worth. That's the literature there. Number 9 is sort of a tangential one. It's about pre-hospital diagnosis and this concept of stroke centers. All of you work in stroke centers? Okay, good. It's coming. Pretty soon that will mean nothing to be a stroke center because everybody is going to be one. But the point here is that there is this regionalization of stroke care. In general, it's to increase the use of TPA. When we do the acute ischemic stroke update, you'll see that most of the things that benefit people, and there are lots of things that can benefit people with stroke, most of it's pretty low-tech stuff. It's taking care of fevers, DVT prophylaxis, swallow studies, PT, OT. Those are the things that make the big difference. The TPA is a modest benefit at best. But that's all predicated still on the paramedics being able to take the person to the right place. So they did the same thing. They gave paramedics a big, giant amount of training, and then they saw how accurate were they when they were field triaging people over. And what they found is, not surprisingly, they had 314 people in this, and it's a little bit of a screwy study. Because the paramedics could bring people in, or the people could walk in themselves, or their generalist could bring them in, et cetera. And they basically said, when the ED doc, when the patient just walked in themselves and the ED doc said it was a stroke, how often was that a stroke? When the generalist referred them in, how often was it a stroke? And when the paramedics brought them in, how often was it a stroke? And what they found was everybody was wrong about a quarter of the time. Right? And they use this as justification for why these paramedics can do this. They're as good as doctors at figuring it out. Now, obviously, the paramedics, cherry-picked the obvious ones, and there's no question about that. And they were frequently wrong. But nonetheless, I think that the take-home here is that still diagnostic humility in the context of acute ischemic stroke. There are a lot of mimics. It's difficult for everybody, including the neurologist, to sort this out. Abstract number 10 tries to delve a little bit deeper into this and tell us if there's any further clinical characteristics that can help us sort through this mess. Is there anything reliable? If they have this, then it's a stroke. If they don't have this, then it's something else, some mimic. So it's distinguishing characteristics between stroke and mimic at the bedside, the brain attack study. It's March 2006, so relatively recent. 350 stroke activations. Ultimately, 69% had a stroke or TIA. So they didn't, they gave, even if you had a TIA, they gave you credit. So 30% didn't. Same sundry list that we've seen before: seizure, infection, toxic metabolic. Those are the big ones. Syncope and vertigo, again, coming into this picture. So those are the categories that we missed. And what did they find when they tried to tease out what predicted what? They found that the exact timing, if the exact timing was known of the onset of symptoms, if there was a definite history of focal neurofindings, lateralizing findings, or a high NIHSS stroke scale, so that's, the NIH stroke scale, if that was high, those things tended to predict stroke. The things that predicted against stroke or towards mimic were if it was a demented person or there were other systemic findings, right? So if the person had cognitive impairment at baseline, they get a little septic and now they're acting like strokey, which I'm sure we've all seen many, many times. Yes, sir? Well, it's hard to, I have a couple thoughts on that. First is, the ER doc probably never did a stroke activation on those ones. I think we're probably pretty good with that. That said, in a couple of the later papers, conversion disorder and psychiatric conditions are a little bit more prominent. So I think both things are probably true, that there is a little more conversion disorder and psychiatric things, and that also when it is that, we're maybe a little bit better at figuring it out, because they're the 20-year-old, who's hemiplegic and is allergic to Haldol or something like that, typical kind of case. So unfortunately, when they took all those variables that were generally predictive and they tried to mix them up and match them together and find some kind of prediction instrument, some constellation of those that would be in any way accurate, they found that nothing was better than 85% accurate. So you just can't do it. Through this data, we cannot find a set of symptoms and signs that will reliably include or rule in stroke or rule it out, which is unfortunate, but I guess the good news is it'll keep paying our bills, because you still need a physician to sit there and try tease through this, and you're still going to be wrong, but at least there's some value in having someone take the real time to try to sort this out. All right. I'm now going to talk just briefly about abstracts 2 and 3. They're great. It's how reliable is CT scanning in the diagnosis of acute ischemic stroke. So, now you're allowed to get a CT scan, and you look in there, and you go, okay, how good are people at figuring out whether this person's a TPA candidate or not on the basis of this CT? So there's a few things that would make you not a TPA candidate on CT. One is if you've already infarcted your noodle, right? If the brain is already infarcted, there's no point in giving TPA. The risk of bleed goes up to at least 8 or 10% in those cases. A totally unacceptable bleed rate. The benefit is gone because that clot is well established. The brain is long dead. So you don't give it then. If there's any hemorrhage, well, that's the biggest no-brainer of all time, right? Don't give TPA to someone who's bled into their head, that kind of thing. And then, there's things, and then there's normal brain, which is what you're supposed to give TPA, or a dense MCA sign or something like that, which you're supposed to give TPA for. The first article is CT interpretation in acute stroke by physician accuracy and such, and in determining the eligibility for TPA. This is by Dave Schreiger. This is from UCLA when I was there. And it's great. 100 people, 100 different physicians, radiologists, EPs, neurologists, and some other guys that were wandering around the cafeteria. And they gave them a bunch of CT scans, but they were subtle. A lot of them were subtle, and they had those ischemic changes that were relatively early, but were an absolute contraindication to stroke. Subtle hemorrhage, things like that, and then normals that would be appropriate. And they asked them how often, they gave them these files, and they said, just tallied them up. How often could they figure out which was which? And you found really tough numbers to swallow. The emergency physicians were correct in saying that this is a good TPA candidate only 67% of the time. We missed a lot of these subtle hemorrhages. But the good news is the neurologists, they were better. They were right 80% of the time. Right? So we missed, 3 out of 10, they missed 2 out of 10. Not good stuff, right? The radiologist did exactly the same as the neurologist, missed 2 out of 10. Overall sensitivity for detecting the hemorrhagic one was only 80%. So this is, caution, danger, Will Rogers, even when your radiologist is helping you interpret these things. Now, TPA guys didn't like this study. This got Dave into a lot of trouble. And so they immediately launched a counter study. It's number 3. Agreement and variability in the interpretation of early CT changes in stroke patients. So they made the argument that, okay, what happened here is that you took the hardest cases of all time, in the history of UCLA, and because they did select the cases, you took the hardest ones ever, and you took the dumbest doctors ever, right? And that's why the results are so bad. You just, the guys who are loitering around, that's who you had do this, okay? So this one is a much better study. It's actual CTs from NINS, and it's actual radiologists and treating physicians in NINS. So these are the very people who were, charged with doing this, who did that, and said, okay, let's interpret the tough CTs in this cohort. And what do they find? Same results. Same results. So 16 doctors, they all had been NINS investigators. They used a neuroradiologist. Final read is the gold standard of this stuff. And they found a big mess. They found that nobody agreed with each other of whether hemorrhage was present or significant infarction was present. The kappa scores, a measure of inter-rater reliability above chance, was like 0.3 and 0.4, dismal, pretty dismal at least. Sensitivity for hemorrhage was actually 78% in this particular set as opposed to the 82%. So, similar, it's similar stuff. So it's not a function of Dave Schreiger stacking the deck against it. It's just tough. When it's subtle, and it's difficult. And that's consistent with all the literature we're seeing here, that you're going to miss a bunch of stuff. It's challenging, okay? The next couple of abstracts are just about lacunar strokes and TIAs. I don't know how much I want to talk about that. 12 and 13. 13 is probably the more relevant one. This is a big, giant stroke trial that was done. It has nothing to do with TPA. It was about glycine or something. But what they did is at 6 hours, they asked everybody to guess what kind of stroke it was, and then they compared that with what the MRI suggested. So is this a big anterior circulation MCA clotted stroke, or is it a lacoon? Right? And then how often we were right or wrong, because that gets into this issue of whether you can give TPA. If you think it's a big anterior stroke and you're always right, that's great, give the drug. If not, if you think it's a anterior stroke and it turns out to be a little bitty lacoon, that's a problem because you're giving someone a deadly drug or potentially deadly drug, and there's no potential for benefit. And what they found is exactly what you'd think. 76% of the time you think it's a lacoon, it is. 25% of the time you think it's a lacoon, it is a big vessel. Conversely, about 10% of the time you think it's a big vessel, it turns out to be a lacoon. So all of this adding up to being a difficult diagnostic case for us. So getting back to your point, and I'll finish up with the last 3 abstracts here. They are 14, 15, and 16, which is, all right, we give up. We can't distinguish them. It's really difficult. In real time, you've got a couple hours, you don't know this patient, you're waiting for them to wake up from their seizure or something like that, or their complicated migraine to get better. You've given them, composine, they're not getting better. You don't know what to do. what are we supposed to do? And again, the TPA manufacturers I shouldn't say manufacturers, a lot of it is just people who really believe. They really want to do this. They really want to give TPA. And our neurologists aren't on the take at our institution, but they love it. Despite the fact that, they acknowledge the data is very poor, they love it. It gives them something to do. It validates their life and all that kind of stuff. Well, otherwise it's just the reflex hammer. Come on. Yeah, they got nothing. All they can do is say, hey, what did the LP show? That's what I do now with all my potential stroke cases. I do an LP and then say they have a contraindication to TPA. No, I don't do that. Because I don't like doing LPs. So the question then is, what if we just give them TPA anyway? Is it safe even in the context of mimic? And there's a couple of hysterical articles here. The first one is Misdiagnosis of Stroke in TPA. This is relatively minor. So one of the arguments was also that sure, when you're not giving TPA, you misdiagnose it. But if you really were going to give TPA, you'd be right a lot. You'd be right. You'd be more careful. You'd get it right. This is just an article showing that in the real world, when you give TPA, proven diagnosis was 10% something that wasn't a stroke. So in the real world, those numbers hold up. Even when it's, you have to make the decision to push the dangerous drug, we're still wrong 10% of the time. They claim that didn't matter much. My favorite of this lot is number 15. It's hysterical. I hope there are no checks in the audience. It's outcome of patients with negative CT angiogram of the brain, results for arterial occlusion treated with IV TPA. So this is a great study. They took 137 people in Czech Republic, and they thought they were having a stroke. They did a CT angiogram on these people. And what they found is 100 of them had a clot, and they gave them TPA, great, whatever. And then 39 of them didn't have a clot. No clot in the brain, right? They got the TPA in the syringe, in the drip, and they're like, oh, there's no clot there. So what do? They gave the TPA anyway, right? So of course, that makes perfect sense. So they go ahead and give the TPA anyway, and then guess what happens? The results between the two groups, those that had the fresh clot and got the TPA, and those that did not have a clot in their brain and got TPA, guess what the outcomes were? Identical. Yes, identical. And so the conclusion is, give it to everybody. It's like, okay, that's one way of interpreting those results. Yeah, that is actually what they conclude, is that, yes, because it works as well in people who had a stroke as in people who don't have a stroke, you should give it to everybody who has a stroke or doesn't have a stroke. It is insanity. I can't believe we're losing to these guys. But whatever, we are. So that's sort of the state of the literature. The last article is a bigger study showing that in 512 patients in community practice who got TPA, a large portion, 21% in this particular case, didn't have a stroke. So we do make these mistakes. They claim that it was pretty safe in that group, the theory being that if you're not having a stroke, your risk of bleeding into your brain is less, which is true. One person did bleed into some small tumor that they didn't know about and had to be emergently rushed to the operating room to have his spine decompressed, but small price to pay. So that's it. It's a beware stroke mimics. They're out there. They're out to get you. It's 10 to 15% of the time, and it's just going to be that way. So, I don't envy any of us who have to go take care of a 60-year-old today that has some hemiparesis or something in light of all this information. I wish I could be the bearer of better news for it, but hey, this is a literature-based course, and this is what it all says. So thank you very much.